Hi, everyone. Thanks for joining. We're just going to give folks another minute to join and then we'll get started. Thanks. All right, as people trickle in, let's get started. Hi, everyone. Thanks so much for joining today's webinar. The hospital is not the home, top lessons from 40 acute RPM implementations. My name's Beth O'Riordan, and I lead our content at Best Buy Health. We're so thrilled to have you here today to have an insightful discussion and explore challenges and opportunities of interpreting data in the home. A couple quick housekeeping items before I introduce today's speakers. First, we do want to answer questions during today's webinar. So if you do have a question, please type it into the Q&A box and we'll get to as many as we can with the time we have left. And second, we are recording today's webinar and we will be distributing that recording in the next day or two. So please look out for that. And Matt, if you want to go to the next slide, I just want to briefly introduce today's speakers before handing things over to them. First, we have Matt Wilkes, who's the Senior Director of Medical Affairs at Best Buy Health. Matt is the lead author of the new research paper that today's webinar is based on, and that is recently published in the Journal of Medical Internet Research. He is joined by Deidre Rolli, who's the Associate Director of Clinical Consulting at Best Buy Health. Together, Matt and Deidre will provide a comprehensive overview of strategies for interpreting in-home data and share some lessons learned from the more than 40 acute care at home implementations that Best Buy Health has had the pleasure of being a part of. And then if you go to the next slide, I'm just going to really quickly walk through today's agenda. We're going to start by discussing the current status of remote patient monitoring, and then we're going to dive into key strategies for interpreting data in the home. We're going to then walk through some lessons learned for RPM care at home implementations before we wrap things up with some key takeaways and some audience questions. So with that, I'm going to hand things over to Deidre.
Thanks so much, Beth. So why are we talking about remote patient monitoring? And it's because remote patient monitoring is on the rise. In 2022, $1.7 billion were spent on remote patient monitoring, and it's estimated that the compound annual growth rate in the U.S. market is going to be 18.4% from today to the year 2030. The key drivers of the RPM growth, number one, of course, we know is the patients. Patients want more access to remote patient monitoring and telehealth visits. And secondly, to the healthcare systems. Currently, there's 50 million Americans using remote patient monitoring devices. 88% of our hospitals and health systems have a plan to invest in remote patient monitoring programs, and 1,300% will be an increase in RPM claims since 2019 in the height of the pandemic to November of 2022. And as we know, we're all being supported by promising government policies. With the thought that the CMS waiver may go away in December of this year, good news came across today. Fierce Health reports that they're hopeful that there will be a 5-year extension for hospital at home and the 2-year extension for telehealth. And the CMS hospital at home waiver allows hospitals to provide acute care inpatient level of care to Medicare patients in the home. Currently, we have 378 hospitals and 140 healthcare systems across 39 states that are leveraging this waiver. Home and community-based services waiver allows states to use Medicaid funds to provide long-term care services in the home, and the goal is to promote a greater independence and quality of life while avoiding unnecessary institutionalization. And then there's a shift to value-based care. More and more, there's improving patient outcomes while reducing costs, and that's an incentivizing factor. CMS's goal is for 100% of Medicare beneficiaries to be part of the accountable care relationships by 2023. That was the goal that they had set. How is Best Buy Health facilitating care in this space? These are just a few examples of some of our partners. If we look at the hospital at home space with UMass Memorial, their readmission rate is 20 to 30% lower than the brick and mortar counterparts. They've saved 3,000 plus beds in their first year when they launched in 2021, and their readmission rate for dual eligible patients was 7.9%, lower than the counterparts that are traditionally taken care of in the hospital. If we're looking at Baptist Health, this was a congestive heart failure program, and after 180 days, the readmission rate was still only 2.4%. There was 0% readmissions in 30, 60, and 90 days. Home hospital research using MGB or Mass General Brigham assessed outcomes of about 6,000 Americans receiving serious medical care at home. There was less than 1% patient mortality rate, and less than 7% care escalation to a 24-hour hospital stay. So the bottom line is care is moving into the home, and more patients are asking for it when they present to your hospitals, and which means that we need to think about how we need to look at the data, especially when we are monitoring patients in the comfort of their own home. And this is what fueled our recent publication in the Journal of Medical Internet Research, led by my esteemed colleague, Matt Wilkes. We've gained extensive real-world experience. We've done 40 plus acute care hospital implementations. We've monitored 34,000 patients with an average length of stay of 3.9 to 7.3 days. And our clinical command center nursing staff has monitored 5,515 patients. And so how do we say that the hospital is not the home? Taking a look at both of these pictures, you can see that there are things that really are different between your hospital setting and the home setting. So from a clinician and a patient expectations, we need a complete reset from what's going on within the brick and mortar.
Thanks, Deidre. So hi everyone, my name's Matt. I'm one of the doctors here. I love being introduced as an esteemed colleague. I'll take that. So thanks for setting the scene, Deidre. I guess what we've shown here is that this is an expanding thing. We've monitored lots of patients. I'm sure there's plenty of people on the webinar who've been part of that journey, have helped us, and thank you. So what have we learned? And I guess what we've learned is that both hospitals and the home are noisy. It's just we're used to the hospital noise. And when we think about a hospital, as Deidre said, it's a highly contrived environment, and you have the kind of perfect patient who, either there lies flat or just kind of sits up and, doesn't say anything. When you count their respiratory rate, it's always 16, whether they're alive or dead. And it's all just kind of very nicely laid out for us. Whereas in the home, they're doing their own thing. And that's great because it's informative. We can meet patients where they are. We can learn from them and from their environment. But also it transfers a measure of responsibility to the patient to collect their own vital signs, either passively by wearing a monitor or actively. And it also means we have to cope with their activities of daily living as well. And so what we need to do is accept that both the hospital and the home are noisy, but we already know how to make sense of the hospital noise because we're all used to doing it. We now need to find a way to make sense of the noise in the home. I need to find a way to move the slides on. So I think one of the things to bear in mind, sort of level setting really, is that, this is what, when I sort of talk to new implementations, it's there's no such thing as a free lunch speech. And it's this idea that if you want perfectly accurate monitoring, then you need an immobile patient in the intensive care unit. I used to do a lot of critical care, and when you had someone who was paralyzed and lying in a bed, you could put wired monitoring on them that responded instantly to every change. It wouldn't work if they moved around, but they didn't move around. But if they were sick, it would pick up the signals really well. It was tolerant of things like low perfusion. None of that's possible if you want to look after somebody in their own home. You can, if you take the example of a healthy young adult going to work as the opposite of an intensive care patient, then they're going to need something that they can put on themselves, that they can wear discreetly, that, yes, there might be a little bit of a time lag, but that's okay because they're not in ICU. It's got to cope with them moving around and doing their activities of daily living. But we kind of accept the fact that it might not tolerate low perfusion states very well, that it might be a little bit less accurate, but it's more acceptable, because what actually matters with remote wearable monitoring is that somebody wears it. If not, it's completely useless. And so we have to accept that when we move someone to the home, we're going to move to the right on this spectrum. So in order that actually, patient are adherent to what they're wearing. And one of the ways to make it more acceptable is to use passive monitoring, so continuous monitoring that just sits on the patient and gathers data. And this has its advantages. The patient doesn't have to do anything. It's always monitoring. So if there's an unexpected health event, it can detect that. But it also means that we have to deal with large volumes of data. And when you want to make large volumes of data consumable, you have to aggregate it, you have to chunk it up so it can be stored. Whereas if you have intermittent data, so for example, a blood pressure measure, then the patient has to initiate it, but you have smaller volumes of data that deal with a discrete kind of period of time. And the interesting thing is kind of when you deploy both at the same time, and this is a slightly busy slide, but to sort of focus on the diagram on the right, this is kind of a common situation we see, and I find it a very interesting one. So imagine a patient who's wearing a continuous passive monitor, and it's measuring their SpO2. But because it's measuring all the time, what it's doing is averaging the data over an hour. That's pretty typical. And so the patient goes to bed, they're lying supine, and then they roll over. And their oxygen saturations start to drop. And they're dropping hour by hour until eventually a predetermined threshold is reached and an alarm is triggered. At that point, the HCP is alerted this patient is desaturated. So they call the patient or their caregiver gets woken up, patient sits up, takes a big breath, and sure enough, their oxygen saturations come back to normal. And if you then do a spot monitor, if you put a finger probe on at this time that's just looking at this little point in time, so imagine where this kind of sort of greeny dot is, then their sats will be back to normal. Now, the continuous monitor that's working on a longer time frame will also come back to normal in time. But then you find yourself with this interesting situation, and we've been in this situation a bunch of times, potentially with some of you, where it looks like the continuous monitor that's looking over a longer period of time is wrong because we trust finger probes, we're used to them. Whereas actually, it's the kind of longer period of time continuous monitoring that's picked up the pathology. And often we see this exact instance in, for example, undiagnosed sleep apnea. And so it's about getting that understanding that these are two different tools, looking at two different windows of time in two different ways. And it's about picking the right tool for the job. And this is kind of one of the themes that will, I guess, develop through the course of this webinar. The other challenge is when the patient's at home, you can't see them. And so when something unexpected happens in a hospital, there's loads of context. So for example, if somebody becomes suddenly tachycardic or suddenly hypertensive, it could either be because they've got sick or because they've got out of bed and had a sudden episode of postural hypertension. And you'd be able to tell that because you're there. But when they're at home, we have to actually differentiate genuine clinical findings or clinical deteriorations from natural variation. So the kind of variation that you might see that's predictable, like circadian rhythms or the menstrual cycle, from things that are unpredictable, like user behavior, going outside, letting the dog in, going to the door, going upstairs to get something, which they don't normally do at that time. Then we also have to rule out user error in terms of how the device is used, or if the device has gone wrong. And we've got to, when we see this single odd looking value, we need to parse all of these things to try and work out what's going on. And that's a challenge. And this is kind of an example just to sort of illustrate that, to kind of put numbers on it. So this is a blood pressure cuff, 510K cleared, so, you know, kosher as far as we're concerned. And this is data having rolled out to 5,500 patients. And the grey bars are just the number of readings taken each day. And you can see this kind of sawtooth pattern because patients were mostly taking them Monday to Friday and then had the weekend off, which I sympathize with. And what I did was look back and say, okay, for every patient, what was the variation to the day before for that individual? And if it was more than 20 millimeters of mercury, which was a number I plucked out of thin air as an eyebrow raising number, then it was a blue bar if it was more than 20 systolic, and it was a red bar if it was more than 20 diastolic. And what we can see is that in this 150,000 readings, every day, between 10 and 20% are of more than 20 millimeters of mercury difference to the day before. Now, why is that? Is that because their blood pressure is, oh, is it because I've broken the thing? No. Is it because their blood pressure has genuinely changed? Is it variation? Is it that they're taking them in a slightly different way each time? Is it that one day they were standing up and pacing around the kitchen, the other they were sitting down for 5 minutes? Is the device being, you know, difficult or erroneous? Actually, as we roll out more blood pressure cuffs, I'm going to repeat this analysis because I think that way I can start to like remove the device component of the whole thing. But it just shows that example of how do we make judgments when we can't tell the full context of what's going on. So these are the challenges. What have we kind of learned to make it easier? So I'll pass back to Deidre for some of these. Oh, you're muted, Deidre, my friend.
Thank you. I guess the takeaway from what you said is choosing and testing the technology to achieve what your specific goal would be, right? It's selecting not what's available, a previous purchase, or what's in the hospital norm, but really thinking mindfully about what you're trying to test on the patients within the home. Give validations to see how the technology actually works on the patients. Is it easy for them to use? And keeping in mind access, make sure that the tech is designed, you know, easy to train the patients, thinking that the majority that are on hospital at home programs are over the age of 67, 68. And do they fit into a broader ecosystem? Is there a way that the technology that your organization is bringing into the home fits into what programs or what vital signs you're trying to capture? And so that's really important. Part of it is that you set out to have a specific goal, and then you choose the technology that's right for what program that you're going to stand up. It's also important to think about what your inclusion-exclusion criteria is for your patients. Like I said, that, you know, there's always that assumption to the crowd that, you know, people over the age of 75 are fearful of technology. And what we actually have found is that in comparison of patients over the age of 75 or under the age of 75, that the likelihood in comparing the comfort is that your older population has more likelihood of being more adherent to using the devices that are in their home. I don't know if it's because they're rule followers, if it's generational rule following or what, but we've proven that among the older patients, the likelihood of adoption is much better in the age over the age of 75. And it's important that when you are figuring out an inclusion-exclusion criteria for programs, is that you don't exclude because of age. And it's important that you focus on building confidence in the technology with your patients and training your staff to be able to verbalize great instructions so that your patients do stay compliant. And comparing the comfort and use amongst older and younger populations, as you can see on the table on the right, it's pretty much adherence-wise, it's pretty much equal. I think that it's also important to set aside that clinicians should expect variable data. I think about, is when you look at an EHR, is on an overnight set of vital signs, like Matt had said, typically on a med-surg floor, a nursing assistant goes in, wakes the patient up before taking a vital sign. If the oxygen saturation is 92 to 93%, they actually ask the patient to take a nice deep breath. Or if their blood pressure may be a little bit lower than expected, then they'll retake that blood pressure when the patient's awake. And that's what gets recorded into your EHR. So as a clinician, you need to expect in the home care setting that the data is going to be variable. And that gaps in continuous data are actually the norm. So you may see that a wearable becomes loose and you may be missing data for a little while. But it's important that you understand that this data can still be used to make really informed decisions. Like I said, the median adherence level is 79%, and our nurses in our clinical command center have managed 5,500 patients, really with about 20% of the data missing if you look at wearables falling off or patients missing a vital sign. And I cannot stress enough the importance of repeating training sessions with your clinicians to set your patients up for success when they are moving into the home setting with RPM programs.
And I think thanks, Deidre, and I think just to build on that, this is the reason why we've thrown this example in as well. Apart from the fact that this population also had an adherence of 79%. I double checked that when I saw they were the same number. I was like, oh, what have I got wrong? But these are kind of our most vulnerable patients. So this example is 40 of our patients with hematological malignancies who are receiving CAR T at home. And as expected with CAR T patients, just over half developed cytokine release syndrome. They were safely managed at home. When appropriate, they went back to the hospital, they got their steroids, they got the TOCI, and they went back on the program. And again, this was possible in this really vulnerable patient group just with 20% of data missing, with just 79% of the data. Even fewer surveys. And interestingly, actually, this group were really compliant with blood pressure, which we don't always see, because that kind of goes a little bit against what we said at the beginning, that people do better with passive rather than kind of active monitoring. I think the thing that this says to me is that we need to think about what adherence is meaningful. It's not we need to have complete adherence. It's not that anything goes. It's that we need to think, how much adherence do we need to encourage in order to feel like we're managing our patients safely at home? And so that brings me on to this idea of a dose of monitoring. I guess when we come from the hospital environment, we just think of this idea of standard monitoring, Q4, nursing assistant comes around and do observations, or whatever might be appropriate in your particular institution. But here we need to think about it as monitoring as an intervention, really, that has downstream operational, clinical, financial consequences. And we need to adjust the monitoring with a patient's progression. It might need, but they need intense continuous monitoring at the beginning. Then they need, partly intermittent monitoring, then intermittent monitoring, and then perhaps even no monitoring at all, or just a daily check-in. And it just has to reflect where they are in their clinical journey. And kind of an example of this dose, albeit a slightly extreme one, is when we, in one of our outpatient CAR T programs, we aggregated continuous data over 15 minutes initially, and that meant that 6 patients triggered 430 alarms in a month. And then when we improved that aggregation, when we broadened that aggregation, so we made the monitoring a bit more specific, then actually 5 times the number of patients triggered slightly more alarms in 4 months. So what I'm saying with that, I guess, is that what I'm saying is actually on a different slide. But what I'm saying with that is that we need to individualize our alarms. We need to recognize that in hospital, baseline vitals are suppressed because really people are just doing this kind of performance when they get their monitoring taken. They're resting in bed, and we use standard thresholds for when we alert people. But at home, there is that variation. People are doing their activities of daily living. And so we like this idea of starting with defaults for population. It might be that in a COPD population, we'll set off an SpO2 alarm at 88%. But we might find that in certain patients overnight, that drops to 86, and that's okay for them. And we need to adjust it as they move through their clinical course. This was the slide I thought I was getting to. But in essence, this whole process of setting alarms is really a balance. In a hospital, we can be happy with alarms that are purely sensitive. All we want is an alarm to go off when something deviates, because then we can open the patient's door and look at them. In the home, we need to add an element of specificity. Now, there are ways to do this. To add sensitivity, you add more alarms, you make the thresholds more conservative, you have those short aggregation windows, like in that example before. To make them more specific, you do the opposite. You have fewer alarms, or you combine them, so there has to be a change in respiratory rate and oxygen saturation for alarm to go off. You have more permissive thresholds, you have longer aggregation windows. The important thing, though, is that if you push either of these too far in the home, if you make an alarm too sensitive or too specific, then ultimately you'll end up with a loss of trust and a loss of safety. And what we find is that there's no one sweet spot, because this all also depends on the capacity to respond. There's no point in having alarms going off every 5 minutes, even if you want that, if you can't deal with them. And so as we roll out a program, we think it's good to start on the sensitive side while being mindful of people's capacity. But as everyone gets confident, to bring in more and more specificity, because that allows patients to recover undisturbed in the home, it maintains trust, and it helps kind of achieve those therapeutic goals, but always being mindful of the kind of clinical risk tolerance of those involved and the nature of the patient cohort.
Yeah, and to add, Matt, is if you think about if you're setting alarms at a programmatic level, it really takes you that 24 hours to see what your patient specifically is doing, and then to be able to be specific to your patient themselves, and knowing that someone's thresholds would be maybe a little bit different than someone else, and being able to adjust those to know your patient.
Thanks, Deidre. Yeah, absolutely agree. I guess this is an example of a sort of hyper individualized alarm, really, but it just shows where we're kind of going with this. So this is actually an inpatient study where we took a group of patients receiving CAR T therapy, and they wore our device as a black box, effectively blinded to patients and blinded to nurses, and they had standard nursing care. And then we worked out retrospectively what the best settings were to detect CRS. And what we found is that if you used just a kind of standard hospital fixed threshold of 38 centigrade or 100.4 Fahrenheit, sort of the standard cutoff for fever, then we could sort of detect CRS a tiny fraction before standard nursing care. And that's kind of cheating, because the nurses were rounding, so we just got there first. But if we just took that patient's 24-hour baseline that Deirdre talks about, and then did 2 standard deviations of their temperature on top, then we were detecting much, much earlier, round about 3 and a bit hours. And actually, as we've gone on to develop this study, we're getting even better results with some of these things that will be published soon. So watch this space for that. So that's where we're kind of going with this idea. But alarms are not everything. And so I'll pass back to Deirdre to talk about rounding, because that's another aspect of keeping a patient safe.
Yeah, you know, is in the hospital, you have that luxury of being able to walk in and out of the patient's room, just to give that visual effect. And I would say you don't want to always solely rely on the alarms. It is really conducting and looking for trends when it comes to remote patient monitoring data. It's rounding every 4 to 6 hours, maybe on your higher acuity every 1 to 2 hours, just to review the vital signs and see if there's any change. Compensatory changes is really what you're looking for when it comes to the RPM. Like, could they be out walking and you're going to see their heart rate increase and their oxygen level decrease, but then you sit and you'll look back at your trends and see that they recovered 15 minutes later. Changes in other vital signs, like I said, the movement, there's recovery after activity. This is all taken into consideration when you're doing these rounds, to actually look and maybe drill down on data to see what your trends have been. And so proactively rounding on patients can really determine if there is a decompensating patient through using RPM.
Thanks, Deidre. And I guess it's also about working out who you can safely ignore, because our goal is that the patients are at home and that we're not calling them middle of the night. So it's using those other proxy indicators to think, actually, this person did this last night, or they've just rolled over. Let's wait and see before we call them. And so I guess this then comes onto this idea of the fact that there just is a learning curve. Like when we look at our clinical command center nurses, they've got really good at being remote monitoring nurses because it comes with experience, knowing, what to ignore, understanding the technology, knowing actually when to worry. But it's really uncertain and really stressful getting to that place. And so I think there's a real place for mentorship as we, as a community, become more experienced at doing remote patient monitoring and care in the home, that more experienced people mentor those who are kind of working their way through this, both on a kind of personal level and also on an institutional level, really. And this ultimately leads to this idea of developing standards of care. And this is happening in things like the hospital at home user group. But it's important because, as we know as clinicians, we're judged on the standards of our peers. And if we're judged on what goes on in a hospital, then that's not really appropriate because, as we've established, we're not in hospital, we're in the home. And so, for example, if you have a monitoring nurse who's doing a really good job at, they've got to know a patient over the last 2 weeks, they know that that patient's saturations drop a little bit every night. And so on a night, they decide to let that patient sleep and not wake them up because of that drop in saturation. If then something goes on to happen to that patient, it'd be very easy retrospectively to say to that nurse, well, why didn't you call them? Their sats were down. In a hospital, they would have been called. Well, actually, that's because that nurse was exercising their judgment for the therapeutic goals of the program. But that's a vulnerable place to be. And until this kind of care becomes the norm and we establish standards, it will continue to be vulnerable. So I think we need to work together as a community to really educate people about the differences between hospital and home and what standards are acceptable in both places. And that's potentially easier said than done. I guess the last point I was going to make, and this kind of comes with my research hat on, I suppose, is that when we set up these programs, all this data that we're gathering is really useful and it's really interesting, but it's only really useful if we have the full picture. And what tends to happen is you end up with this triad where the health, so the patient knows what they're doing at the time, going up and down the stairs or sitting still. The health system knows their past medical history and their treatment course. And the tech provider knows kind of the quality of the data that's coming through, the signal strength or other things. And if you have all three of those bits of information, then you can come to meaningful conclusions about what you're seeing in the data. If you only have one or two, it's harder to do that. And so if we are going to set these standards and if we are going to do meaningful research in this context, we need to find ways of uniting these three things in a way that all parties benefit. So, coming to coming to an end here. I guess what we've been trying to say is the home is as noisy as the hospital. It's just we're used to the hospital. And now patients are in the home, we have to interpret these in a new context. And that means giving clinicians time to gain experience, the tools to interpret the data, and setting standards for those who are, new or trying to set up these programs. I'm conscious that in a lot of this webinar, we've talked about the differences and the problems. We've only in some ways touched on the solutions. And I think that's because these solutions are evolving and we as a community are evolving them. But if we do fully embrace the care at home model, and we think we should, and we use remote patient monitoring appropriately, then I think we can really deliver excellent care. Thank you very much for listening. I look forward to any of your questions. I actually look forward to knowing that any of you are alive, because all we can see is a black screen. So I've just been shouting into the void.
Thanks so much, Matt and Deidre. And thanks to the audience for asking a lot of great questions. They are alive out there, Matt.
I've not seen any prove it.
We're going to use the rest of the time we have today to tackle some of the questions you all asked. So let's dive in with the time we have left. Matt, there was a slide that showed an image of a man outside with a dog, presumably in his garden. And so one of the questions was, do we have clients who really demonstrated a willingness to allow patients outside their main, room of recovery, so to say? And if so, what helped them build that confidence to be more flexible with their hospital at home program?
That's a really good question. I'm going to defer to Deidre on it because she's closer to that kind of thing.
Yeah, absolutely. You have to think that, once the patient is feeling more, I'm going to say, like themselves, they are going to want to continue with their ADLs. And if going outside and walking their dog is one of them, then yes, it's thinking they're in their own environment and we're guests in their house. And if they have the energy, it used to be, the day in the hospital where every patient was asked to walk the wards, for recovery. And if they're doing activity, then yeah, they go out into the garden. And I guess we're fortunate because if they are if they do have passive monitoring with what we offer for devices, is all of that data gets backtracked. So it goes on nursing assessment in the morning. If they're feeling well, their vital signs are stable, then they can go out and do their thing. I wouldn't say, it's not approved to go to the mall, but if they're in their home and doing their regular daily activities, then that's encouraged.
Thanks, Deidre. I think more broadly, what would give me kind of confidence where we need to get to from a technological perspective is something that, can be worn at all times. So be it cellular connectivity or something else that doesn't require being tethered to a home hub, which means that you don't have to rely on backfill data. There are downsides to that, though, in terms of its usability and also context. And so that would then have to come with an ability for us to understand what the patient is doing at the time, to contextualize it without the patient feeling like they were being monitored intrusively in terms of what they were doing. So I think it's a good question. There's a way to go with the technology, but there's also just the confidence of, as Deidre said, being a guest in the patient's home rather than them coming to us in the hospital.
Great, thank you. There was a question on slide 21, which was looking at the variations in systolic and diastolic blood pressure. The question was about if those readings were using the same blood pressure devices.
They were.
Okay, wonderful.
But what I would like to do is see the same setup with a different device, because then we could start to tease out device from patient factors.
Great. The next question is, can you talk a little bit about any concern in terms of missing a significant health event when you're missing some of the data like you've talked about?
I guess it depends what you mean by concern. I mean, I'm always concerned about not doing something safely.
Yeah, I think the question is there a concern that you may be missing a significant health event if you're missing some of the data monitoring at home?
There is, and I think that's the that's the risk that we have to take upon ourselves as clinicians monitoring patients in the home. I think in a hospital, I mean, data is frequently missed in a hospital, so the hospital is not perfect for that. If the nurse is rounding every 4 hours and there's something else going on in the ward and other things, plenty of things are missed there. But I think when the patient's in the home, we are one step removed, and certainly response times are longer. And so we have to accept that there will be a higher level of risk potentially of missing something, but we hope that that is outweighed by the health benefits of them being in their home, of them moving around, being able to recover undisturbed, lower risk of nosocomial infection, all of these things that we think of as sort of overall therapeutic goals of care in the home, but they outweigh the risk. But there will be a risk there, and from time to time things will be missed, and that I think is something that we have to accept, albeit we are constantly wanting the best and the safest for our patients.
Wonderful. Thank you, Matt. The next question, there was an interesting question that came in around caregivers. What kinds of challenges have you seen in getting a caregiver to set aside time for both education and involvement in the use of technology? Deidre and Matt, I'll let you guys weigh in.
Deidre, fire in.
Yeah, absolutely. As before patients come on to hospital at home programs, if there is a caregiver involved, then the organization or the healthcare system really does a great job. At least our customers that we work with, or in my previous life doing this work for an organization, is we always looped in caregivers to make sure that they understood the responsibilities. There's a lot of talk about caregiver burden. But if you think about in the brick and mortar setting, is doctors round when family members aren't there. So they're not looped into the holistic approach of your patients. And the caregivers actually enjoy that piece. So that bit of education, that bit of learning that your team needs to do actually is more of a holistic view for your patients when they're in these programs.
Thanks, Deidre. I've been reassured by the data around caregivers because I was kind of worried about that. I live in the UK, and the NHS has a noble tradition of shifting responsibility away from the NHS to other organisations. And so I was kind of worried that we would just be shifting the burden of responsibility to caregivers. It does seem, based on the data that's coming out, not just from us, but from other organisations, that actually caregivers do appreciate that opportunity, the holistic care that Deidre has described.
Wonderful. We have about 3 minutes left, so we'll get to one or two more questions. There's a lot still rolling in.
They're alive. I need
The next question is, are you seeing patients that still don't have internet access at home? And for those that do, has internet strength been an issue, or is most of the monitoring via cellular?
So not to show off, but that is the advantage of our home hub, is that it has both cellular connectivity and internet, as in broadband. It used to be that we would rely on the patient's home broadband. Actually, we found that cellular is better now, so our primary coverage is via cellular.
Great. And then Matt, could you give an example of a longer aggregation window, for example, with oxygen saturation data?
Sure. So typically we say a median over 60 minutes. So effectively, because it's a median over 60 minutes, something's got to be out of whack for just over 30 for an alarm to trigger. That would be the standard hospital at home recommendation. For our most vulnerable patients, we sometimes drop that to 30 minutes.
Great. And one last question. How frequently have you found that the technology in the home is either not used properly, damaged unintentionally, or not maintained properly? So, not switching the batteries out, for example. Can you speak to that?
Go for it, Deidre.
Let me get myself off of mute. I guess it's just another thing that Best Buy offers, and I'm not trying to give a plug, but our Geek Squad agents we usually handle all of the reallocation and the reprocessing of equipment. Battery life is a quick charger. It gets put into, especially in the hospital at home setting, that if a wearable needs to be charged, it gets put into the workflow, and that's educated. The workflow of the nurse that goes into the home will actually charge the battery when they're in there. Personally, in this space, I have not seen big gaps in the equipment itself. From batteries dying, or if a battery does die, then it becomes an alarm in our setting. So it would be a reminder for the patient to charge the battery. So I hope that helps.
I think that's the important thing, isn't it? Is knowing when something's not working. So it's having an alarm or having something that lets you know when the wearable isn't transmitting, rather than having to rely on finding out from the patient.
Wonderful. We are at time. I want to thank Matt and Deidre for a great presentation, and thanks to everyone in the audience for participating, listening in, and really asking some great questions. Like I mentioned up at the top of the hour, we will be distributing the recording in the next few days, so please look out for that. And Matt and Deidre, I'll just throw it really quickly back to you, parting words before we end things here.
No, thank you, Beth and Danny and Katie, for organizing this, and thank you very much, Deidre, for presenting it with me, and thank you all for coming. It's a great community to be part of, and I'm really excited with where we're all going with this.
Thanks, everyone. And I've asked for Santa's list to have the CMS waiver extended. So I'm with everyone here on this call that I'm hopeful that things will keep moving, and we will continue this great trudge of moving care into the home. So thanks, everyone, and enjoy your holidays.
Thanks, everyone. Happy holidays.
Bye-bye.
Bye-bye.